has remained fairly unchanged. So the issue here is not about the mortality nowadays that you are dealing. There is a number of improvements that have been done recently, especially developments in the intracranial pressure monitoring. So mortality is, especially this paper is done in the high income countries, but the issue, the favorable outcomes, because we know the patients who are undergoing the traumatic brain injuries, sometimes they do have the things of the degenerative neurocognitive diseases. So those are the issues that they try to do. So apart from that, we know that most of the traumatic brain injuries, they are done in the prospective cohort studies. So most of the data that we do have, they have some sort of the high dimensionality. So sometimes when you are trying to capture to try to see the outcome, when we're trying to do any sort of analysis, sometimes the data can be messy. So sometimes it's really hard to deal with an outcome directly. So this is the reason that most of the studies that are done in the clinical settings, for instance, this paper was done at an ICU setting, some sort of the data. So that's why sometimes they do emphasize us to use and supervised machine learning, because that one can better deal with the data which has high dimensionality. So this is the paper that methodology-wise, so this study was done, it included about 2,006 patients from the center TBI, which is an ICU cohort, and with a focus on adults who were aged around 18 to 14 years. And the study was conducted between 2014 and 2018. And these patients were presented within the 24 hours of TBI, and they required a CT scan. So the inclusion criteria in this study, they included patients who had a clinical diagnosis of the traumatic brain injuries, and also they admitted to ICU immediately after the hospital arrival. So they also had some sort of the feature selection. When I say the feature selection, I mean the variables that were of interest to actually train the machine learning to create the patterns out of it. So in this study, they had 35 early feature selection with over 2,000 parameters, and these were based on the clinical relevance. The features from the impact model for the outcome, for the TBA outcomes, and also some of the features that they selected, they're the features who were known with the plausible associations with the outcome. And also they were associated with some sort of physiology related to the traumatic brain injuries. For instance, some of the features that selected were the Glasgow Coma Score, the lactate level, the oxygen saturation, the serum creatinine, the imaging scores. And also, so after they did this feature selection, they selected clustering model. So in this paper, they presented that the clustering model that they used was the probabilistic graph mixture model, was used because they mentioned that this one do handle both discrete and continuous variable effectively. It also do manage missing data without requiring imputation, which is also critical for the ICU data set. As we said, these are the data set that they have high dimensionality. So a lot of mixing can be anticipated, for instance, in prospective cohort studies. And also the algorithm that they chose in this paper was the expectation maximization algorithm, which was applied. And in the expectation maximization, this one had actually like two steps out of it, while the first one was the expectation stage. And this one do estimate the probability distribution over the clusters for each patient. And the maximization step is the one which updated the cluster parameter to maximize the likelihood. And also they did some sort of iterations until the convergence to deliver the most probable cluster assignments. I'll get time to explain each of these separately. So this is what they did, the expectation maximization algorithm. And after that, they went further to determine the number of clusters. So in the determination of the number of clusters, they used
Virginia,
yes.
can you go up and look at the variables again that they use here in this
Yeah.
table?
Yeah,
Can
this one.
you comment on a few of these if we have something similar in our registry, or how applicable it would be?
Yeah, okay. I was actually going to that, but thank you for stressing that earlier. So some of the variables which they used, for instance, majority they ranged from social demographics, the clinical, as well as the imaging parameters. But from our registry, we basically have the demographic. We also have clinical as well as the injury characteristics. For instance, some of the variables that they use in the feature selection, things like the pH based excess, the lactate, the glucose, platelet count, creatine, hemoglobin. These are the ones we do not have in our registry. And also from the CT scan, things like the classification further of the Rotterdam CT score. These ones we also do not have, like the Fisher classification we are missing. So, but they used it in their feature selection based on their the clinical knowledge out of it, and also the neurological association with this. Yeah, so I'll further explain what I chose in my analysis.
And it
Sorry,
seems
can I
that
ask?
the
Yeah.
variables were collected at admission, right?
These ones were collected, yes, within 24 hours, but these ones were at ICU.
Okay.
Yeah. So if at
Admission to
ICU,
ICU.
I
Okay.
understand why they had to go further to metabolic parameters, things like lactate, platelets count.
Mhm.
Yeah, which is different from our registry because we have the data from a patient which was captured at the emergence.
I see. Thank you.
Yeah, thank you for that. So I was here on the determination of the number of clusters. So they used the cluster stability index. This one was used to evaluate the stability of cluster assignments for different cluster numbers. So this one ranged from 3 to 15 clusters. So the models were run with different random seeds, and the log likelihood was calculated from each. And the median cluster similarity index was penalized for the number of clusters to prevent overfitting with an excessive clusters, and optimization was determined to be 6 clusters, as we'll see in the results. And also the balancing and stability for the clinical interpretability was what was decided. And also they also had some sort of the evaluation of the clusters, whereby they had this feature importance and the mutual information. So this one was used because this one it do quantify how well each feature was differentiated between the clusters. So the key features like the Glasgow Coma score motors, motor and the total scores, lactate, oxygen saturation, the creatinine, the glucose, the base excess, the pH, and the body temperature were among the features we had the mutual information of more than 0.5, which was considered to be an important for cluster differentiation. Yes, I will explain this further. And also in the analysis, they used the logistic regression to assess the relationship between the cluster labels and the features. And they employed the multivariable regression, which evaluated how cluster labels improved the outcome prediction, where the outcome there, they were assessed, they were taking the GOCE, which is the same as what we are having in our registry. So we know the GOCE has the categories from 1 to 8, 1 death and 8 to be the full recovery. So this one they did at 6 months post-injury. So they are following up this patient. So the cluster labels were added to the impact extended model for outcome prediction. And they actually found there was a statistically significant improvement in the model predictive power for both mortality and unfavorable outcomes. So that was just a nutshell of what they did in the analysis. So I just want to explain some few things which I learned out of this paper. So first of all, regarding the model that they use, the probabilistic model. So this one is a mathematical way to do the grouping by finding the patterns in the data. So in this case, when you want to graph patients into the clusters based on the various characteristics, for instance, in this paper, we saw they had a number of the variables, for instance, the age, the sex, the type of injuries. So you want to group the patient into clusters based on these characteristics. So what I learned from this paper, they explained this model as a very flexible and powerful for data which is messy. Like this one, this was an ICU data. And the data which has multiple variations. So as it can deal with both number and categories at the same time. So they had both numerical, they had both quantitative and the qualitative data. So by using this model, this could capture all those. And also, I went further to learn how does this work. So the model actually, they do use the expectation maximization algorithm model. So as I explained earlier, this one which has the two steps, the E step. So in the E step, the estimation one, the model guesses which cluster each patient might belong to based in the availability data. For instance, it might assign like 70% chance of a patient to belong in cluster A, 20% chance to belong in cluster B. Also, it can also assign, for instance, 10% of the patient to belong in cluster C. So in the maximization step is when the algorithm try to adjust the clusters to better fit the data based on these probabilities. For instance, it might update the definition of the cluster A to include patients with high glucose levels. So this is how these algorithms work. And also, I mentioned something about the iterations. So in the iteration step is when these steps are repeated until the model stops improving, which is what they call the convergence. So meaning that the clusters are as good as they can get. So why do they do some sort of iterations? So iterations is like, I learned this actually not in this paper, but I went further to learn like, why do people have to do these iterations? So I just had this some sort of explanation. It's like solving a puzzle. So whereby each iteration gets closer to the best solution, refining the cluster definition and the membership. And how do you know like it has converged? So convergence happens when the changes between one iteration and the next one are very small, meaning the model has stabilized and it's no longer improving. So after that, when I went further in the puzzle analogy, the algorithm worked like assembling the puzzle. So it first guesses where the pieces might fit and then move them around to make them a better fit, repeating this process, that's the iteration, until the puzzle is complete. So in determining the number of clusters, I mentioned they use the cluster similarity index. So in the cluster similarity index, we said it measures how reliable the clustering is. So if you run the model multiple times with slight random variations, the cluster similarity index tells you how often the patients are grouped in the same way. So why the cluster similarity index? So this one do ensure the clusters are not random, like they are overly dependent on one run of the model. So a high cluster similarity index, meaning that the clusters are consistent and they trustworthy. So we know that in this study, they had they presented to have like the 60 clusters out of it. And this is how so like, how did they decide like it's actually 6 clusters that they had? So they actually tested, you can see in this picture here, they actually tested the number between 3 and 15. And for each number, they checked the cluster similarity index and their log likelihood. And also, just to tell how well the model fits the data. So they chose 6 clusters because this one had the best combination of stability, like the highest cluster similarity index and the practical, and in the meaning that it's not too many clusters and it's not too few clusters. So this is like testing. Yes, I think I shouldn't. Yeah, this is the picture of what I was trying to explain. We can see here there are 10 models of each number of clusters between 3 and 15 were created. So the model with the highest log likelihood was chosen as the best model, and this one was repeated 20 times. And finally, they were able to see the one which had higher cluster similarity index was chosen to be at 6 clusters. So yes, so feature importance was done, and yes, so we could see like factors like glucose level was helped to differentiate between the clusters. And if the features had a high number of it means that it's very important for telling the clusters apart. So its usefulness is based on the highlighting the most critical factors for defining the clusters. For instance, features like the Glasgow Coma score, motor score, glucose, and the lactate. Yes, they had that number, meaning that they were essential for distinguishing between the clusters. So on the outcome prediction, they also wanted to see if adding the cluster labels, for instance, in cluster A, to an existing predictive model, they have this impact model whereby they used to see how best does it predict the outcomes. So by including these clusters to see how it improved its ability to predict the outcomes. So where outcomes data like survival, recovery was not useful to create the clusters. So this one kept some sort of unbiasedness. And after creating the clusters, they added the cluster label to the impact model and to see if it improved the prediction of the mortality and the favorable outcomes. And they found that after adding the cluster labels, it improved the model's accuracy and is slightly, but to a slight significance, but it showed that the clusters had a real clinical meaning and are not just mathematical constructs. So when we go to their results, they actually had like a total number of patients who analyzed there 1,728, whereby 278 were excluded due to missing 6-month GOSI data or the outcome data. And the mean age of the patient were around 50.4 with a standard deviation of 19.3. And predominantly they had males who are around 73.4, and the causes of injury around those who had road traffic incidents were around 46.4, and also the falls were around 43.7, and mortality of 22%, and those who had unfavorable outcomes were around 45%, which these mean like they had the upper severe disability or worse. So this showed nearly half of the patients, they had unfavorable outcomes, and it showed the importance of finding better way to classify and treat traumatic brain injuries, as it was explained in the introduction part. So the optimal number of clusters that they had in this study, they were like 6 based on the cluster similarity index, as I explained earlier. So the patient distribution across the clusters, for instance, in cluster A, they were around 497, cluster B, they were around 262. Yes.
Virginia.
And yes.
Can we look at figure number 3 on the page below?
This one.
So that's the one we were talking about, the number of clusters, right?
Yeah, this is one I was talking about.
Yeah, so just to visualize here, so they say that the optimal number was 6 because if you add more clusters, you don't get much improvement.
Yeah.
In this CSI, right, which is the cluster similarity index. And this decision was basically they're saying that they tested a bunch of combinations that you showed on figure 2. And this year they decided upon 6, correct?
Yeah.
Nice.
Yeah, so they further explained these characteristics of the clusters. I think I'll just go straight to this table. Yeah, this one. Yeah, so the thing is, each cluster had distinct clinical and physiological profiles, and the key features which were differentiating the clusters, it included like the Glasgow Coma score, which were both motor and the total, and also metabolic profiles. For instance, in cluster A here, we could see these patients were the patient who had the mild traumatic brain injury with no metabolic derangement. And these were basically classified as the older patients who are often on anticoagulants. And these ones, they only had 7% mortality. And in cluster B, these were the patients who were classified to have the moderate traumatic brain injuries. And these patients had no metabolic derangement. And they are the older females, typically with falls and midline shift from the CT scans. These are the patients who also required some decompressive craniotomy. And they had a mortality of around 29%. And also the cluster C, these ones were the patient who had the moderate traumatic brain injuries with a significant metabolic derangement. For instance, they had high glucose and lactic acidosis. They also had hypothermia, worse outcomes compared to the cluster D. So the thing is here, if you see the patient in cluster D, these are the patients who had the severe forms of the traumatic brain injuries, but this patient had normal metabolism. So we usually know, like in the traumatic brain injuries, the patients, by using the usual classification, the Glasgow Coma score, we usually think the patient who have the severe forms of the traumatic brain injury, the patient who usually have the worst outcomes. But in this study, we could see these patients in cluster C, they just had the moderate forms of the traumatic brain injury. But also what was added here in this cluster, these are the patients that had the moderate traumatic brain injury, but they had the metabolic derangements. So that's the reason that this patient had the unfavorable outcomes compared to the patient in cluster D who had like a severe forms of traumatic brain injuries in the usual classification by using the Glasgow Coma score. So that was something that was high notice in this paper. And also in cluster E, they're the patient who had the severe forms of traumatic brain injury with a slight acidosis and hypothermic profiles. Sorry. Yeah. And also they had higher Rotterdam CT scores with the midline shift who are often requiring surgeries. Either the patient had only 38% of the mortality. And the last cluster, the patient in cluster F, these are the patients who also had the severe form of the traumatic brain injury with a systemic shock and metabolic acidosis, hypoxia, and hypoventilations were common. Their mortality was only 28%. So all I know, like what I learned from this presentation here, this shows the importance of combining the neurologic and the metabolic data. So this is what they did from their study because they had metabolic data. They combined the neurological in terms of the Glasgow Coma score, but they also incorporated this metabolic data to see how further machine learning can tell the patterns of the patient with the traumatic brain injuries. So yes, so the take-home message from this study that I had, the study actually challenges the traditional traumatic brain injury classification and also showing the metabolic profile can influence the outcomes independent of the Glasgow Coma score. And actually, by identifying the endotypes, so the clustering in this study, this actually may help develop tailored treatments, some sort like management of the metabolic profile in the clustering. For instance, like we can tell how further we can see, for instance, the patient with the moderate form of TBI, but they have metabolic derangement. So we can at least see how we can centralize care in this type of patients. So this is what I learned out of this paper. The rest is just
Can you scroll to the table? I think it's table 3 that maybe would answer William's question. Let's see, table 4 actually. So we have the clusters. Wait, table 4.
Table
Yeah, that
4.
one. That one.
Yeah, this one.
So we have the clusters there, A, B, C to F, and we have the mortality down there. William was asking about if these patients had other injuries as well. Let's see if we can find any description.
Oh, here.
We have Gaussy. No, so this is injury severity.
Yeah, the reason I'm pointing that question, actually, this is great, Virginia. I'm really impressed. It's a lot of statistics and mathematics, which is, I think it's partly part of the requirement. But I'm just curious, like these proposed clusters, and of course, I understand that they decided to use the clustering mode as the unsupervised approach. I'm just interested to know, like, this of course they use the ICS score, but it's very tricky if you can go to the figure which you just explained that there were patients who had very low GCS score, like the D part. Patients had a GCS of 3 to 8, like their eye opening like was really low, like, but again they had good pupillary reactivity despite having low GCS. Like, I was really interested to know if we had, if these patients maybe had other forms of injuries. Did they take that into account?
Look, maybe table 3 describes a little bit more. Let's see. D has severe TBI, no metabolic derangements, younger patients, RTIs. Yeah, so RTI, good pupil reactivity, severe TBI, no secondary insults. So I believe no secondary things, and the mortality is really low as well, 18%.
Okay.
Yeah, and also I don't know if I can answer that regarding if they had other injuries, because I also asked myself that question and then I went back to see the inclusion criteria. I think perhaps, they were taking things from the registry. Yeah, but the inclusion criteria were the patients who had the traumatic brain injuries. And since it wasn't really specified in their feature selection, like this patient has traumatic brain injuries and other injuries like with it, that one, it's challenging to tell, but I get your point.
Yeah. So at the end of the day, like, what did they propose? Like, they challenged the GCS. They provided latent classes that can help stratify patients by taking into account their metabolic derangements. So what is the take-home message from this? Like, should we use the GCS or should we use the GCS with an eye of other parameters? But again, we are using GCS to derive these parameters. Like, what is the take-home message? That is the question that I also struggled, because we were working papers with latent class analysis, and we got it's unsupervised form of learning, and we got the clusters. But like the translation of that was the tricky part.
Yeah, so I get your point. You know, one thing about this, it's a data science. So I learned like people there from this paper in perspective. Of course, it's we do have GCS, but we also look it in the line with other metabolic parameters, because that's what they were trying to address in this study. But also I saw other papers whereby they also had some sort of GCS, but they also incorporated like the comorbidities out of it. I think I can also share a screen. Sorry. I think I had it in my Zotero.
So sorry for you.
Yeah, no, it's okay. It's okay. It's okay. Yeah, this one. Do you see this paper?
We are still on the clustering paper. I think you need to share your whole screen.
Oh, sorry. How do you see it?
Can you cancel your sharing and share again?
And share the screen, not the document.
Okay, that's tricky. But can you see like the title, identification of the clinically relevant patient?
No.
No, I think
Let
you
me-
need to
What we
stop.
see is
I
what we
will-
had initially.
Sorry. Should I share the screen again?
But share desktop this time around.
Oh, desktop, sorry.
Yeah.
Anyway, I think I'm having trouble. Sorry.
No problem. Take your time.
Yeah, when you're prompted to share, do not select any specific document. Just share your entire screen.
Yes, now we see Zotero.
Yeah, sure. Sorry. So I wanted to answer to Williams. So from that paper, they actually incorporated the Glasgow Coma score, and they also have some sort of the metabolic parameters. But in this paper, they they were also trying to see these ones. They had this statement here. Yes, here. So in this study, they were trying to identify clinical relevant patient endotypes in TBI using the latent based on the comorbidity data. And in this paper, they actually identified 5 stable endotypes by using comorbidities like heart failure, arrhythmia, renal failure, hypertension, alcohol abuse, and hypertension. So it's tricky because I think people try to learn the patterns of the data and the traumatic brain injuries based on what they have and the problem which they created. And finally, in this paper, when they did, of course, they identified like 5 endotypes by using the comorbidity data. And each endotype, they had a distinct clinical characteristics and outcome. For instance, here they said the heart failure and arrhythmia endotypes, they did survive actually. They had a lower survival rates than the renal failure with hypertension, despite fewer comorbidities overall. And also they saw like the patient in the hypertension endotypes had higher rates of neurosurgical intervention, but shorter stays in contrast to the patient who had the alcohol abuse endotype. So overall, they actually found that the logistic regression model showed like all endotypes improved predictability of the survival compared to the individual comorbidities alone. Like, but from the paper which I did, it's also showed like the endotypes, which they further had it's some sort of improved the predictability of the outcomes compared to just use the traditional classification by using the Glasgow Coma score alone. So it depends with what you want to address, but as long as we use the unsupervised machine learning, it can just further tell the endotypes that you are having from the data that you are presenting. So that depends with what you are doing. I don't know if I've answered your question.
Yes, Virginia, you answered well. Thank you.
Okay.
Yeah, Virginia, thank you very much for that presentation. I perceive it to be somewhat complex, but I see how you made it easy to understand. I just wanted to ask, the mortalities that they had there, were they kind of risk-based, as in, was it a kind of follow-up? Were they just prevalence-based?
They were follow-up because their outcome score, they were followed within a period of 6 months.
Okay.
Yeah,
Okay,
so
okay.
it's not like a prevalence. It was a follow-up.
Cool.
Yeah.
That's good. That's even better, I would say. Having both the in-hospital or in ICU mortality, but also the follow-up could be, I believe, adds an additional value to the model, or I mean, to the study as well, showing that the model was able to consider this long-term outcome as well, which is something that we often miss from our studies because we have data from ED, from ICU, from discharge, but we often don't have follow-up to understand what happens to the patient afterwards.
Okay.
Cool. Very well done, Virginia. Very interesting. And I think that the reasoning that sometimes gets some conflicts in our minds is we often try to make sense of what the machine is giving us. So this being an unsupervised machine learning model, it is sometimes abstract, right? So by naming the groups as the authors did, for instance, the cluster A was very mild patients, for instance, with no metabolic derangements. So this is a name that the person gave to this class that the model created. But sometimes, basically, we cannot find patterns, we cannot explain it. And the thing is, can we justify the creation of these new clusters versus what GCS already did? And to the end of the day, I really believe that if we can use those clusters to improve patient outcomes, say, as William was discussing, say if we take that cluster E or D, which was a severe TBI patient and had good outcomes, and we basically focus our attention to maybe a different group which had mild and had more severe outcomes. I don't know if we can actually do that. I think it makes total sense. But then it's something that becomes sort of abstract. It just pays to the future and validate this with new patients and make sure that the clusters are stable, as Virginia was discussing as well, as new patients are enrolled and we start doing predictions as well.
Yeah, so thank you, Joel, for that clarification. So I remember during the presentation, you were trying to ask the feature that they used if we have in our registry. So I mentioned it's not all the feature that they use that you have in our registry. So we have things like the demographic, the clinical, and also the injury characteristics. For instance, the Glasgow Coma score, or for instance, the injury, whether the patient required surgery, or whether the patient required an ICU admission. So I'm still in the process of feature selection and doing some sort of cleaning. I think maybe a month later, I'll be able to present what I have found in terms of the feature selection and in terms of the model that I've decided to use and what I've found preliminary. So this was just what I've learned from what others have done, but I'll share my presentation maybe a month from today to see what I've started doing.
Awesome. That's
Yeah.
a nice plan.
Yeah.
And also, Virginia, just a highlight, like meanwhile you're working on your features, I don't know if what unsupervised approach you're going to decide using, because we have different, and I think you're aware of that. But for example, the paper you presented, they used the cluster, and the second one you presented, they used the latent classes. But I think you should know this. Also, we have principal component analysis. It's also a form of unsupervised approach. That will help you identify the clusters. So within that, I don't know which one you're going, and I think it could be helpful to know, like, when will you decide to use latent class approach as your unsupervised approach, like, or when will you use the cluster form, or when will you decide to use principal component analysis or structure question modeling as your approach. And I think that depends really on the nature of your data and what you're trying to answer.
Yeah.
But I think you're moving in the right direction so far. Yeah.
Yeah, thank you, William, to mention that as well. Of course, from the last presentation which I had, of course, I mentioned like 3 algorithms out of it. But as in still, I'm in the process of feature selection and to see how my datas are. And provide, I think I love this probabilistic one, which I presented today regarding, but I think I'll have a room to do different algorithms to see how best they suit my data before deciding which one I'll go with it. But it's good mentioning. Thank you.
Yeah, just thinking a bit out of the box, except I'm mistaken, but I kind of realized that the sex distribution is like 75% male and 25% female. And while this may be a distribution of patients in that facility, I'm not sure if that represents actual population distribution. So looking at it through the lens of performance of the algorithm, what do we think about that? If we had to apply this to the general population, wouldn't it be a little more biased? Because, I mean, the population that was used to train didn't typically reflect the population distribution in terms of sex.
It depends. It could match. Might as well just match the population we do have for the registry at KCMC as well. We have a predominance of males for injuries overall, and I believe that should be overall the same for TBI. I think that William and Virginia can say more about that. Do you know on top of your head what is the proportion of male and female we have for TBI?
Well, I can get that information, but I agree with you, Joel, that males are also more like we see more males in TBIs compared to females. Yeah, of course, and Obari's concern, of course, it's varied because it somehow doesn't reflect the entire population, but in the injury world, I think males are more affected compared to females. So maybe it reflects the injury population, like speaking in that regard, I would say. For example, in my study, like the proportion of males, the total population of males who basically had poor outcomes of TBI were more like they were 87.1%, and females were 12.9%. So that means even in our data, we are seeing more of male patients with TBIs compared to female.
Yeah.
And this, I think, applies to all forms of injury. But Obari, I think you're right. Like this population, really, we would want to have a balance between the two populations. But I think in the injury world, this is not the case, regardless of where I would suggest. So maybe this reflects what is happening, I would say. I don't know if that could be the right way to think through it, but yeah.
Yeah, I kind of agree, but at the same time, there could be a huge potential for misclassification, whereby immediately the algorithm sees male, like, oh, probability for maybe death or whatever the outcome is pretty inflated automatically. So, but again, I don't know exactly the best ways to handle such that we are at one part making sure that it truly reflects the population, and then at the other part, it's also a reflection of that particular disease condition, as is in the case with injuries. Yeah, I don't know whether there's anything like stratification such that with something like this, we develop two models, one specifically for male, one specifically for female, just to avoid that kind of bias outcome. Just food for thought.
Could Joe Victor, could we try and maybe do the balancing issues like the ones we use for vaccine techniques, just to make sure? I don't know, but that will be the features. I think that applies more to the outcome where we oversample and undersample, like just to make sure that kind of equal representation. I'm not sure if that applies to the features.
Yeah, there are many steps to this question. I guess that the first thing is that this is the unsupervised model, so it's not giving you performance. It's not giving you cannot measure accuracy or ROC AUC just now from the classes. You would basically need to classify patients in those things, in those clusters later to be able to measure that. But once you do it, then it becomes a question. The question about it is there bias? So the way that you can assess that, you can do a sensitivity analysis where you select only males and only females and you measure the accuracy. Is it equal enough? Does it have like a margin of error that is acceptable? Or do you actually see that the model is not good for females? It's making like 20% of mistakes extra. And then when you notice this, you start trying to address either by doing what William was saying about oversampling or by adding some sort of a calibration fix. So basically you start with the question. If you find a bias, then you try to address it. But I guess this would be the next steps after transforming this to a predictive tool and not only to this clustering approach. Let me